Welcome everybody to the third Anne Klibanski visiting lecture series. My name is Louisa Sylvia. I'm the director for the Office of Women's Careers within the Center for Faculty Development. And in today's session, we have Dr. Amanda Zayde from Montefiore Medical Center and our very own Dr. Ellen ODonnell will be talking about supporting the mental and behavioral health of emerging adults. Before we begin the formal presentation, there are just a few announcements I'd like to make. First, this session is being recorded and will be made available on the CFG website as a webinar and a podcast. And with that, I'm just going to get into a little bit of the background here as to why we're all gathering. And this is part of the Anne Klibanski Visiting Scholar Award. And this award has been really important, I think, for a lot of women faculty across not only our institution, but also the partnering institutions. To help people to get the opportunity to do speaking engagements virtually during COVID. And we're going to kind of continue this program because we've gotten great feedback. This is really helpful, not only in speaking more and getting more visiting professorship and lectures, but also in networking and collaborating with other women across institutions, which has been wonderful. And it's named after our very own Anne Klibanski, who's the president and CEO of Mass General Brigham, and who is a very accomplished clinical researcher, and who also used to be the former director of the CFD. So she's sort of the perfect person to name this after, because she really highlights many of the things that we hope all of our women faculty will be able to do, which is have these wonderful, successful careers of clinical research here at Mass General. And we've had 2 rounds so far of our Anne Klibanski Scholars. This is the first group, our first year of scholars, and this is our second group of scholars this past year. And somewhere here is Ellen, there she is, in red. So we're thrilled to have Anne as our scholar here with us today. And we're also thrilled, as I said, to have Amanda here from Montefiore. There she is, also in red, so both highlighted. And both, again, thrilled to have you guys doing this today. And the actual lecture series, as I mentioned, really brings together faculty members from MGB as well as from other institutions. And we continue to grow the institutions that we partner with. And it's really been a wonderful opportunity, as I said, to collaborate and network and foster good working relationships with many people. So with that, I'm going to dive into our speakers. Again, we're so excited to have 2 wonderful speakers today, both clinical psychologists. Dr. Zayde is in the Child Outpatient Psychiatry Department at Montefiore. She's the director for the Connecting and Reflecting Experience Clinical and Research Program, as well as the associate director for the Psychology Internship Training Program. Lots going on. Also the co-director of the BEAM program and assistant professor at the Department of Psychiatry and Behavioral Sciences. So again, wonderful to have you here. And then we have Dr. Ellen ODonnell, who's also, as I mentioned, a psychologist, pediatric psychologist in our child and adolescent service here at Mass General. And she's the director of psychological services in the MGH Pediatric Endocrinology and Diabetes Center for Shriners. And also the 2 of these folks have a lot of overlapping credentials, because she's also the co-director for the MGH Internship in Child Psych. So both clearly clinicians and educators and researchers, a lot of overlap, which is wonderful between these 2. All right, with that, I think I have said just about all that I've needed to say here to get us started. So I'm going to help advance Dr. Zayde's slides. And with that, take it away.
Thank you so much. Hi, everybody. I am very excited and deeply grateful for the opportunity to be here today and to be collaborating with Dr. ODonnell on one of the topics I feel most passionately about, which is emerging adulthood. And to demonstrate our commitment to today's topic, please enjoy these photos of us from when we were navigating our own phase of emerging adulthood. Okay, we can move forward. So a bit ambitious, but I think we can do it. By the end of this talk, you will be able to explain the unique developmental milestones of emerging adulthood necessary for the transition into adulthood, discuss how the trajectory of emerging adulthood for patients with mental and medical illness may be impacted by both contextual and individual factors, including social determinants of health, describe strategies and challenges for developing and tailoring clinical interventions to meet the unique needs of emerging adults, and identify a variety of resources available to support the development of emerging adults. Okay, so let's get started. So what is emerging adulthood anyway, right? It's not quite adolescence and it's not quite adulthood. Rather, it's really a distinct developmental stage that is often described as feeling in between the two. Emerging adults are developing increased autonomy and independence, while they're also engaging in exploration and development of their identities. Emerging adulthood is also a critical time in the development of a wide range of psychopathology, including, but certainly not limited to, anxiety disorders, eating disorders, psychotic disorders, major depressive episodes, and increased substance use. It is critical to incorporate both individual and contextual factors, such as things like culture, social determinants of health, and identity, when conceptualizing the developmental trajectory of emerging adulthood. And also, I felt like it was really important to note sort of in the beginning of our talk that although some may think about emerging adulthood starting at 18, which makes sense. I think historically we would see people really moving from child to adult systems of care like right when they turned 18. I would encourage us to think about emerging adulthood rather as a developmental stage that's really best characterized as a fluid, complex, and an interactive set of processes rather than a discrete age-bound stage. And we'll talk about why this conceptualization is so important just in terms of assessment, treatment, and transition planning. Okay, so I know we're on Zoom. I really sort of like to imagine that we're all in a room together. And so just for this moment, please feel free to unmute and shout out. When we talk about the unique developmental milestones of emerging adulthood, what are some of the things that come to mind for you?
Getting a job.
Getting a job. Did I hear two people maybe?
Going to college.
Yes, going to college. Anyone else?
Living independently.
Yes, thank you. So these are all great answers, right? So school, work, getting a job, going to college, living in
girlfriend, boyfriend.
Thank you, girlfriend, boyfriend.
$5 bill and then $4 to $5 bills for change. So I want to get $20 cash, but in
That
fives.
is not an emerging adulthood.
One $5 ticket. Sorry about that.
Okay, it sounds like they need it. So identity development, relationships and sex, self-care, all great answers. And so let's talk a little bit about the factors that may impact the trajectories of our emerging adults as they begin to navigate this new terrain that you've all mentioned. Okay, so these are results from a large prospective study of over 1,000 participants. And as you can see in the blue and the green, we have rates of psychiatric illness and substance dependence that are increasing significantly during the transition from adolescence to emerging adulthood. And in yellow and red, you can see a steep decline in service use. So despite the importance of this developmental period, and as we mentioned earlier, the emergence of a wide range of psychopathology, emerging adults are actually among the least likely to access and remain engaged in treatment. And the National Comorbidity Study similarly found that 18 to 24-year-olds had the lowest rates of any mental health service use, less in both adolescents and adults. And then importantly, once they do access services, emerging adults are also more likely to prematurely drop out of mental health treatment. This, really, you can imagine it being due to a number of factors. It may reflect ambivalence about the treatment process that they may or may not have self-initiated, or may reflect developmentally common deficits in the organizational and planning skills needed to manage regular appointments. So emerging adulthood is not only a critical time in normative development, it is also a period of time when individuals are particularly vulnerable to increasing rates of psychiatric illness, just as their likelihood of accessing treatment and remaining in treatment decreases. So the other thing to hold in mind is that I feel like oftentimes we're more likely to think about how psychiatric symptoms can interfere with developmental milestones, like going off to college, starting a job, or even being in a new relationship. But this is really actually a bi-directional relationship. And so the presence of new developmental expectations can also lead to the exacerbation of psychiatric symptoms. So some examples would be like an emerging adult going to college for the first time and experiencing new social demands, and then maybe experiencing an increase in social anxiety, or new independence and uncertainty about how to navigate various milestones can lead to increased substance use. And finally, like often ambiguity inherent in graduating high school and facing these new developmental expectations with increased independence can serve to exacerbate mood and anxiety symptoms. This is why preparation for the transition way before this launch is critical, and we will talk more about that. Okay, so it's also critical for anyone working with emerging adults to be consistently thinking about how health disparities impact the launch into emerging adulthood. Many of you may be familiar with the name Dr. Jeffrey Arnett, who about 20 years ago proposed the term emerging adulthood. He gave this great TED Talk. It was entitled, "Why Does It Take So Long to Grow Up Today?" He talks about 4 changes resulting in this new life stage of emerging adulthood. He talks about the technology revolution, the sexual revolution, the women's movement, and the youth movement. It's a great TED Talk. I highly recommend going online and watching it. At the end, Dr. Arnett does say the following: "This is an unprecedented and unparalleled period of freedom. If you'd like to see what it's like to live in a different part of the world for a while, now's the time to do it. If you'd like to try and be an actor or a musician, this is the time to do it, because right now, nobody else really depends on you." So as a psychologist working within a diverse and under-resourced community facing multiple health disparities, the statement didn't completely resonate, right? So while it's certainly true for some, it didn't feel particularly inclusive of the many emerging adults who lack the knowledge and resources to render such choices possible. So it's imperative that we're holding in mind that multiple domains of poverty-related challenges must be taken into consideration when we're working with emerging adults. So one of the things that we know is children living in poverty often experience their environments as unpredictable and uncontrollable due to things like substandard housing, inconsistent transportation, crowding, noise, just unmet basic needs, right? These experiences often cause chronic stress, which can negatively impact both executive function as well as cognitive flexibility. These difficulties are further compounded by inadequate academic preparation. So the lower the mean income per neighborhood, the lower the college readiness for that community. In addition, emerging adults in poverty lack social resources to guide them through the process of considering various post-secondary pathways. So for example, half of low-income high school seniors do not have a parent who attended college, so they may not be able to rely on parental experience to guide them through the process. Also, peers, neighbors, classmates, and families of low-income students are also less likely to have attended college, which just further limits their social resources. In addition, low-income families are less likely to have internet in their homes, making it more difficult for them to acquire information that they're unable to obtain from their social circle. So all of these factors have the potential to significantly impact successful achievement of post-secondary goals, or actually even knowing what post-secondary goals are available to them. And then finally, some additional factors that I won't dive into too deeply just because of time, but also impact the mental health and behavioral health of emerging adults. We have lack of research, although I think we're getting a bit better, delays in initial contact with mental health treatment, transition between clinics, high treatment dropout, and few treatment adaptations. So we've talked a bit about multiple challenges facing emerging adults. What do we do? One idea that Dr. O'Donnell and I want to focus on today is to develop specialty programming to address the unique needs of our emerging adults. So at Montefiore, the wonderful doctors Sandra Pimentel and Amy Kranzler and I co-developed the BEAM program. So I'll quickly read. The BEAM program aims to develop, implement, and evaluate developmentally informed policies and interventions for emerging adults with a wide range of presenting concerns. Our goal is to offer assessment, treatment, consultation, education, and training to improve our ability to meet the needs of emerging adults as they present to and transition among clinics across our health system. So I'm going to briefly describe some aspects of our program. Okay, so the LEAP, which stands for the Launching Emerging Adult Form, developed by Anne Albano and colleagues at Columbia, is a fantastic assessment tool that youth fill out at intake beginning at 16 years of age at our outpatient clinics. It gives us a real sense of readiness for independent functioning on a variety of domains, as you can see quickly: independent tasks, work in school, recreation, relationships and sex, self-care, it helps us to tailor our interventions and provide appropriate scaffolding for our emerging adults. And then what I found is that it can also really be used as a fantastic clinical tool. So I had a patient who was transitioning to college and was aware that sort of she didn't know certain things, but almost like, I don't even know what I don't know and what I am supposed to know. And so we went through this together, and I think it served to really ground her in an understanding of the skills that maybe she needed to become more proficient in and that we could work on together. And then we have this shorter self-assessment form that emerging adults can complete perhaps every few months in treatment to track their growing proficiency in multiple domains. And it also can be used in part to assess readiness to transfer to an adult system of care, which we will talk a little bit more about next. And if we're thinking about emerging adulthood as a developmental phase with multiple domains, there are so many things to consider when making a determination about readiness to transfer to an adult system of care, right? This idea that they just transfer right when they turn 18 doesn't really make sense when we're thinking about it this way. And so considering things like whether your patient is in high school or in college, whether they're currently psychiatrically stable, where they are in their self-assessment tool can all be really helpful indicators. Once it has been determined that they're ready to transfer, we really want to be thinking about a warm handoff to increase the likelihood of successful transfer. And we want to have continuous coordination between child and adult systems of care to help facilitate the transfer. So I went through those extremely quickly. If you want more information, we've included a lot of it in this paper that we've written. I also love talking about this, so feel free to send me an email at any time and I can go through it in more detail. Okay. So one of the things that can happen, even when we start to think about development from adolescence to adulthood as gradual, is that we will still tend to think about the process monolithically, because one set of skills, when really development happens across so many different domains at different rates. And so it can be really helpful to think about development in a domain-specific way. So as a separate set of unique skills that we can support emerging adults in developing. One of the things that we recommend that we found really helpful and successful is co-developing a developmental hierarchy. So similar to exposure hierarchies, they can really help guide treatment in terms of areas of skill building and transition planning unique to the emerging adult that you're working with. I want to take a moment to say that, when I was in training, there was definitely some messaging around it not really being our role to do things like help with a college essay or practice interviewing skills or, co-create emails to professors. And at this point in my career, I would argue that all of these things absolutely fall within our purview. And in fact, I don't think we can separate them out from our patients' overall mental and behavioral health. That doesn't mean that it's only on us to provide this type of scaffolding, and I'll talk a little bit more about how to develop community partnerships in just a few moments. I also want to note, sorry, it did seem like I wanted to advance. It was a long pause. I also want to note that even if you're not the person developing a hierarchy, I think it's two back. If we can go back, if not, that's okay.
I will get there. Oh no. Oh geez, I was doing so well.
Spoiler alert, everybody.
Okay. Oh geez.
Don't worry.
How do I get out of this? Oh, should just go. Am I going the wrong way?
No, you just backed up. One more.
There we go. Okay.
Amazing.
Sorry.
That's okay. What I was going to say is I just want to note that even if you're not the person developing the hierarchy with the emerging adult, you can still be thinking about their proficiency in the skills that impact your work with them. So that can be things like, are they able to refill a prescription? Or do they know how to put appointment reminders in their phone so they actually show up to your appointments with them? And then we also want to make sure that we're talking with parents of emerging adults about the importance of taking a step back so that their child can begin to take lead. Now I am ready. Thank you so much. Okay, so it's also so important that we support parents in determining the appropriate use of scaffolding, which is really a balance of providing support and encouraging autonomy. And that balance is really contingent upon what's right for each family. This sometimes requires helping parents to to manage their own anxiety when it comes to allowing for independence and potentially having to, tolerate their kid making a mistake or making a decision that they don't necessarily agree with. And or helping parents to better understand the ways in which emerging adults continue to need support around tasks of independent living. So things like registering for classes or how to interact with a professor during office hours or what questions might be asked on a job interview. These are all things that emerging adults may have never done before and need some support in understanding and navigating. Okay, here is a snapshot of some of the specialty program that we've developed for BEAM. Huge shout out to Dr. Sandy Pimentel, that is her photo right there, who developed the fantastic college readiness group, which I love. It's about 5 or 6 weeks for high school seniors, although sometimes we'll have high school juniors involved. There's a focus on the intersection of mental health as well as developmental and transitional tasks. So these are things like, how do you deal with peer pressure? How do you register for classes? How do you manage your time? Something as simple as like, how is high school different from college? How do you make friends? How do you identify a mentor? And so there are handouts, materials, and resources, and it's phenomenal. There's also the What's Next group, because college is not the right next step for everybody. And oftentimes there are information gaps here that we need to help out with. So what are potential post-secondary pathways? What is an interview like? What questions might they ask? How do you create a resume? Differences between trade schools and colleges. Also, informing people that there are fee waivers. There was one moment where I had an emerging adult years ago say to me, too late. I only applied to one college because that's all I could afford. I never, ever want that to happen again. So letting kids know that there are fee waivers and subsidized possibilities if they can't afford college applications. We also briefly had a virtual town hall where we invited emerging adults from our whole community that didn't necessarily have to be patients at Monty, where they got to talk about how the pandemic impacted their lives, their feelings about the presidential election at the time. We did a voter registration drive to help our emerging adults register to vote because their voices really matter. And then, as I mentioned earlier, I think it's really important that we create community partnerships with organizations that can provide additional scaffolding for our emerging adults and their families. So I've put a few here. I mean, I work in the Bronx, so these are in the Bronx community, but there are services like these in most communities. We have Bronx Works. They have a great young adult internship program. Emerging adults can actually earn money while going through orientation and training, and then they receive follow-up services for months, for 9 months, to be specific. There's also the Bronx Works Cafe, which supports high school students and their families on just the transition from high school to college. So first of all, that FAFSA form is a beast. So they receive support with that. And then visits to college and college counseling to really try and determine, how do we think about goodness of fit? What are the factors that matter? And then there's also iMentor, which is a program that pairs students from low-income communities with mentors, and they have a mentorship relationship for at least 3 years. And I didn't include it on here, but I thought it could be helpful. There's also the JED Foundation, which is a national organization, and it has a number of extremely helpful resources for anyone who might be working with emerging adults. And I'm sure there's many more. Okay. there are a lot of folks to acknowledge, but I'm just going to name a few to be quick. I want to thank, of course, Dr. Sylvia, the Office of Faculty Development, the Office for Women's Careers for having me here today. I'm really, really honored to be here giving this talk. I want to thank Drs. Sandy Pimentel and Amy Kranzler, who you can see in that photo, who are my dear colleagues and Beam co-developers. I'd like to thank the best mentor imaginable, Dr. Tom McMahon, who really fostered my interest in emerging adulthood. I want to thank Dr. Ellen ODonnell for being an outstanding collaborator. And finally, I want to thank my greatest supporters who are also here and who gave me just the right amount of scaffolding and independence when I was an emerging adult, my mom and dad. So thank you all so much.
Wonderfully done. Thank you so much. I will stop sharing so that Dr. O'Donnell can get her slides up. And I think what we'll do is we'll save quite, well, if there's one burning question we'll take now while Dr. O'Donnell gets set up, and then we'll also hopefully a little bit of time at the end. Are there any burning questions you can either put in the chat or unmute?
Oh, and of course, my second screen decided to fritz out at exactly this moment, but I'll figure that out in just a moment.
I can ask something. So thank you so much. Fantastic presentation. And how do you get, well, my boys are a little bit younger, but how do you get the kids involved in actually doing your program and doing all these activities? Because I think it's awesome and they should do all your letters, everything you showed, but how do you convince them that that's the best for them?
Yeah, I think that's a really great question. And I think oftentimes we really listen to the emerging adults about sort of what's important to them, what are their values. Oftentimes, like, they're really excited to gain some independence and to receive some scaffolding. And so, to be honest, most of the time, sound okay? Most of the time, they are pretty engaged as long as we're listening to sort of what they feel passionately about, what their values are, and what they want to pursue.
Great, thank you. We'll try it at home.
Good luck, Miriam. And there's another question in the chat about what is the referral process for the program, Amanda?
Yeah, actually, I would say one more thing, Miriam, which is, I think like Sandy's just brilliant in every way. And one of the things that's so cool about her college readiness program is its group. And sometimes I think when you put emerging adults with other emerging adults, sort of increases their motivation and they get excited and they can do role plays together and practice skills together. And so that is one other tip I might have. The referral process, we have a referral form. It's within our health system right now within Montefiore. I think I put my contact information on that slide. Feel free, I mean, you could just Google me and all my information's out there and I can talk you through a referral process.
Great. Thank you so much, Dr. Zayde. And without further ado, it looks like Dr. O'Donnell's ready to go.
We'll see.
Great.
Let's see. Hopefully you're seeing just slides and not notes. Okay,
Yep,
excellent.
all set.
I was so glad to, Amanda, we didn't talk about it, but that you mentioned the FAFSA form, because I can say that I spent, I think, 2 hours on the help line for my own emerging adult with FAFSA this weekend, all to determine that the problem is that I put the apostrophe in O'Donnell on the parent portal, and my 18-year-old did not put the apostrophe on the student portal. And so, you know, I mean, I'm bringing it up sort of jokingly, but I think one of the things we'll talk about at the end, especially, is really just what are our roles as mental health clinicians or doctors and care providers in supporting emerging adults. And if I'm struggling with that with a PhD in psychology and I can't figure out the FAFSA form, I think we have to acknowledge that this is a really challenging time for all families. So I'm going to talk a little bit about the specific example of supporting the mental and behavioral health of emerging adults who also happen to be coping with type 1 diabetes. And I'm going to assume that most of our listeners know what type 1 diabetes is, but just at least in brief to kind of review that type 1 as opposed to type 2 diabetes is an autoimmune disease. And it's also known as insulin dependent diabetes. So anyone with type 1 is having to take exogenous insulin, either by injection or insulin pump. It can have short-term consequences, including severe hypoglycemia or low blood sugar, as well as diabetic ketoacidosis resulting from acute high blood sugar, which often either of these can result in a visit to the emergency room or a hospitalization. And then there are also long-term physical consequences, things like diabetic retinopathy or neuropathy, increased risk of heart disease and stroke, and an overall shortened lifespan. Most relevant to my work as a diabetes psychologist is that type 1 diabetes is a chronic illness and it really affects patients' quality of life. So anyone with type 1 diabetes is required to follow a pretty complex medical regimen of daily blood glucose monitoring, either with finger sticks or a continuous glucose monitor worn under the skin, multiple daily injections or wearing of insulin pumps and other devices, carbohydrate counting at every meal and snack. And so I really kind of describe this as kind of a constant running dialogue at the back of the mind at all times, sort of thinking about what did I eat last? When did I last take insulin? What might I eat next? When you're really regulating your own metabolism, or, you know, with some maybe support early on from school nurses and parents and other adults, but as we'll talk about in emerging adulthood, with increasingly less support from others over time. And so people with type 1 diabetes, we know, are certainly at risk for diabetes-related distress and burnout. They also seem to be at higher risk for depression, at about 3 to 5 times higher risk. And the reasons for that are probably multifactorial and not fully understood, including maybe some underlying biological mechanisms. But the way that I tend to think of it most is really that, you know, when we feel depressed or when we feel anxious, it's often because we feel out of control, that we feel like we are not in control of what happens to us and the outcomes, and feeling really helpless. And when you think about trying to manage your own metabolism and your own blood sugar, even if you do everything exactly the same day after day to manage type 1 diabetes, the outcomes are often very, very different. And so it's sort of the definition of feeling a lack of control that can contribute to things like depression and anxiety. And we also know that there's a high degree of diabetes-related family conflict, especially in adolescence, which is very relevant to the age group we're talking about today. Let's see, there we go. So type 1 diabetes is one of the most common chronic illnesses of adolescence and young adulthood, and its prevalence is increasing each year. So it affects more than 1 out of every 500 youth. And the other piece to note is that rates are increasing disproportionately in BIPOC youth, such that the demographics of T1D have shifted pretty dramatically in the past 5 to 10 years. And something that we really need to be taking into consideration as we're developing different supports and interventions. So young adults with diabetes or emerging adults with diabetes are a unique population to care for due to the spectrum of developmental readiness and preparedness to independently manage their diabetes. Some will be much more ready than others. There's also a high frequency of comorbid mental health issues that complicate diabetes management, like I mentioned, increased risk of depression and anxiety. And then there's the evolving nature of their social determinants of health, including education, work, finances, family life, that often compete with the responsibilities of diabetes care, like blood glucose monitoring, medication adherence, and attending doctor's visits. And we know that the impact of poorly managed diabetes in emerging adulthood has ripple effects on patients' ability to achieve those important developmental milestones of emerging adulthood that Amanda so nicely highlighted for us, including things like educational, psychosocial, financial, and developmental milestones. And often the gaps in care that would support a more successful transition of patients with diabetes from pediatric to adult care become apparent too late. It shows up once they're already having transferred care to an adult provider. So we really want to think about there being a difference between the transition stage of really becoming more independent in managing one's diabetes and being prepared to be even more independent. And then that's different from the actual transfer of care from pediatric to adult care. And oftentimes, like I said, we're really not noticing what was missing or maybe even what wasn't taught until patients are already engaged with adult providers. And then we learn that they've let a prescription lapse because they really didn't ever learn how to keep track of renewals and knowing that you will eventually run out of authorizations, and that you have to get that before you can refill a prescription. So they'll run out last minute. Those sorts of things become apparent when they're now in a setting where they're maybe not getting as much support as they did in pediatrics. And the American Diabetes Association notes that patients who are making that transition from pediatric to adult care are at elevated risk for diabetes complications, often due to those differences in care models. There's a little less support even from MDs and certified diabetes educators or nurses in an adult clinic than there might be in a pediatric clinic. And so because of those differences in care models, patients tend to be lost to follow-up. There's less parental involvement. And of course, that's complicated by issues of confidentiality and whether or not providers can even contact parents, even for emerging adults who are over 18. And then also psychosocial risk factors like increased substance use or being uninsured or underinsured in that transition age period between being on parent plans and getting one's own insurance. So that period of emerging adulthood really encompassing the years sort of, I would include beginning in high school, but certainly after high school into those years of assuming more typical adult roles can be really challenging for patients with diabetes. And as I said, they're also being expected to take increasingly independent responsibility. And to some degree, some may have been taught and others may not have been taught what they need to know to independently manage their own chronic disease. And a lot of that might even depend on when they were diagnosed. So oftentimes I'll see adolescents who were diagnosed in toddlerhood or preschool or elementary school. And sometimes we assume that they know certain things because they've had type 1 diabetes for so long. But in fact, it was their parents who were taught carbohydrate counting or, dosing when the insulin pump fails and you go back to injections. And they actually never were taught those skills because the onset of their illness was at a time when they wouldn't have been responsible for that. And so patients are really at increased risk for diabetes related to stress, and they might perceive themselves as having either not enough support or maybe too much control from others over their diabetes, and really be struggling. And of course, this is all in addition to the normal stresses and pressures of adolescence and emerging adulthood. And we know that diabetes related distress in turn relates to decreased motivation for self-management and associated poorer glycemic control. So then now we're looking at increased risk of hospitalizations and other complications. So as Amanda so nicely highlighted for us, it's really kind of this bidirectional relationship between the developmental tasks of emerging adulthood and the challenges of managing T1D, where difficulty in either exacerbates the other. There's also a lack of mental health support that we're all very much aware of, especially in this post-pandemic period where the need is only increasing and the supply of mental health services was inadequate to begin with and really now cannot keep up with the need. And so where there's increasing risk for depression and anxiety and substance use at this period in time, we have that decrease in utilization of services, which is probably for a lot of factors, but one of which may be the lack of availability of services. And just in terms of that bidirectional relationship, I just want to note too that especially in adolescents and young adults, poor glycemic control is associated with things like lower academic performance. Hospitalizations due to complications can affect school attendance and learning. And because poor glycemic control can so quickly turn into life-threatening conditions, parental anxiety is very high, and parents tend to be very fearful of what could happen if their emerging adult doesn't meet the developmental tasks of their diabetes management. And unfortunately, high parental anxiety can also tends to translate into high parental control, controlling behaviors, controlling styles of parenting, which can not only impair adolescents' development of independence and self-direction of their diabetes management, but can also really undermine their intrinsic motivation even to take care of themselves, and really also contribute to that increase in diabetes-related family conflict at this age and stage of development. So that was a lot of bad news, a lot of really discouraging information. And yet we know that there are actually ways to protect against these challenges and to build resilience in emerging adults with type 1. So there's some good qualitative data to suggest that effective communication technology, so even using existing diabetes technologies to communicate more effectively, for example, between patients and providers or patients and parents, things like education and preparation prior to the actual, this says to the transition, but I'm going to change that to prior to the actual transfer of care. So prior to that move from pediatric to adult clinics or models of care, having that education and preparation in advance. And crucially, especially from patients' perspective, the availability of social and peer support are really important and key factors to patients and families to help them to have this be a more successful period of development and transition. And to accomplish these goals, the ADA actually recommends that pediatric diabetes clinics take a multidisciplinary approach and include a diabetes psychologist or a social worker to provide this kind of support to help build resilience and support this transition. And so what might that look like? It can include a number of different pieces. This is from that ADA expert consensus. So initiating transition planning at least 1 year before that actual transfer of care. So talking about what will be important and what an emerging adult might need to know or accomplish before they actually make that transfer from pediatric to adult care. Working with caregivers and patients to facilitate that gradual shift of responsibility. The scaffolding that Amanda was talking about, the ladder, sort of how do we gradually work toward increasing independence in key dimensions of managing a chronic illness. Providing practical information on the differences between clinics. Could be as simple as explaining that when you miss an appointment with an adult provider, the chances that they are going to reach out to you maybe even once, let alone more than once, to reschedule are much less than perhaps in a pediatrics practice. So if you miss an appointment and you get that automated message that you missed an appointment, it's now your responsibility to call and reschedule. Very basic kind of just practicalities of the differences between pediatric and adult models. Assisting youth with compiling what they'll need to make that transfer of care. What documentation do they need to bring with them? Are they going to be seeing a provider who's within the same system and will still have access to their medical record or not? That's going to impact that actual transfer. Acknowledging and providing support around the developmental and psychosocial challenges unique to this age group. And I'm going to put a pin in that one because that's what I'm about to talk about next. And also the importance of screening for psychosocial concerns. So anxiety, depression, eating disorders. The ADA has some recommendations about yearly screening for these conditions beginning as early as age 10, but certainly in emerging adulthood. So we know all this. This can work, this can help, we know what to do, but why aren't we doing it? Because still less than 15% of patients with type 1, ages 22 to 30, report having received even written information relevant to their transition or having had any kind of conversation with a provider about this transfer of care before they make that move from pediatric to adults. So if we know what to do and the ADA is telling us what to do and we have all of this information from research, why aren't we doing it? We decided to try to address this gap here at MGH in the Pediatric Diabetes Center by developing the T1D Transitions Program. And I have to give a huge shout out to our social worker, Mary Bennett, who has really spearheaded the development and leading of these groups. And so this is a program where we have Zoom sessions twice a month at different times of day, and patients who are 15 years old and up are all invited to participate. And the program provides individualized support to help to increase patients' independence in their diabetes management and to facilitate that eventual transfer of care. So it's a supportive peer group setting where Mary makes an effort to kind of schedule people who might be in similar situations, whether they're going to college or they're choosing not to go to college and they're working instead, to try to sort of pair these small groups of emerging adults who might have similar concerns. And so they have that peer support and they share their concerns related to various aspects of their lives and their diabetes management. They set and track their progress toward really specific goals. And Mary helps to identify supports who they might need to reach out to help them meet those goals. So for example, if their goal is to refine their carbohydrate counting, then they might need to make an appointment with the nutritionist. And again, we try to hold these virtually. They're held on the same day as our multidisciplinary clinic for all ages. And so we try to sort of keep that together. And the content development has been led again by myself and by Mary Bennett. And it includes self-assessment of transition readiness, setting goals. We have some video education materials on different topics that have been developed by the multidisciplinary team. So for example, type 1 in the workplace or at college, alcohol use in type 1. And then there's some additional yearly programming for parents and adolescents, like an off to college night that's really spearheaded by our lead nurse, Leah Berthold. And we have some other sessions in development as well. So the program draws on evidence-based supports in behavioral medicine and motivational interviewing to really try to improve patients' ability to meet the goals to be increasingly independent in their diabetes management and to hopefully achieve at least close to goal glycemic control and overall quality of life. So very similar to some of the tools that Amanda shared with us, this is just an example of the self-assessment of transition readiness. So sort of rating oneself on readiness to do things like writing down questions before appointments, sharing your medical condition with others, keeping your insurance card with you, knowing what your insurance does and doesn't cover. And the color coding you can see here is because if I'm not feeling like I'm on top of one of these things, then it helps me to identify which member of the multidisciplinary team might be best able to help me to progress on that particular thing to feel more ready to tackle it. And again, this brings up that there is not an arbitrary age that just magically says I'm now ready to transfer to adult care. It's really about meeting the developmental milestones of emerging adulthood and sort of having a set of specific benchmarks that we help you scaffold toward in order to actually be ready to make that transfer of care. And so in this way, even though it is a group intervention and there is kind of a general curriculum, it's also kind of a model of individualized medicine and individualized goal setting. This is an example of the goals sheet where we might help patients to set what we call SMART goals so that they're specific and measurable, achievable, realistic, time limited, and help them to sort of make a plan to achieve those goals. This is just a little clip from one of the educational videos that we have where we're talking about how do I communicate about my diabetes, who needs to know and what do they need to know. This is in that sort of domain of social development of emerging adulthood. And right now we do have some funding from the Harvard University Milton Fund that I received to evaluate the program, at least to have an implementation project. And so we're taking a participatory action research design, which means that we're doing qualitative interviews with participants in the transitions program and focus groups with our MDs and nurses, our providers, so that we're getting some feedback on the program and using that information to kind of tweak things and make changes at the same time as we're also evaluating things like change in diabetes related to stress and rates of anxiety and depression and things like that. And so I won't go into a lot of detail, but this is sort of a timeline of where patients who are in the transitions program are enrolled in the study and they fill out some surveys and then they have their interviews and we're kind of refining the program as we go to sort of evaluate it over time. There have been some challenges, and I think the challenges in our research study are really reflective of the challenges of working with emerging adults in general. So we have had some challenges with recruitment, as we do in many research studies, but we've also had some challenges with follow-up. So we've had patients who say, yes, I'm in the group and I want to do the study, and then we can't reach them for a follow-up phone call. You know, what is the best way to communicate with young adults and emerging adults? Unfortunately, doesn't always match up with HIPAA compliant means of contacting them. So we're not allowed to text them, but they would prefer a text over an email, these sorts of things. There have been some challenges with provider engagement. Providers have very limited time in their visits with patients, and they have checklists that they need to address of medical concerns and benchmarks. And so having the time to not only let patients know about the program, but really sort of engage in the kind of conversation that might motivate them and interest them to participate is a challenge for providers. And it requires a lot of administrative support in terms of that outreach and contact and keeping in touch with patients who are enrolled in the program. And those are not things that are necessarily covered by insurance. And so it requires funding, money and time, as most things do. And then, you know, we're also facing sort of some of the more expected challenges of just working with emerging adults. So when do we transfer to adult care? We don't have an arbitrary cutoff at 18 in our clinic. It tends to be once patients have sort of maybe graduated from college or are working and have decided where they're going to settle. And so that if they're going to settle in the Boston area, then we would transfer them to someone either at MGH or nearby. And if they're going to be moving, then they'd be transferring elsewhere. Very exciting. One of our MedPeds fellows who might be here right now, Janaki Vakaria, is doing her project. She's developing a young adult diabetes clinic within our adult endo program, where she has a social worker available with her for these specific visits for this age group of 18 to 35-year-olds to provide some of the additional support that's unique to this age group. And that does allow us also to do that warm handoff that Amanda was talking about from the pediatric clinic specifically to Dr. Vakaria, where we can say to them, you know, this is where the adult clinic is, this is what it looks like, this is who you will be seeing, this is when your visit will be and what it will be like. But there are still challenges. You know, we really need to think about how we get insurers and other stakeholders to see the value in these kinds of services, to fund them, to support them. And how do we really engage patients and families and prevent that loss to follow up that's sort of pervasive in this age group. So that sort of just brings us to some common themes that I think Amanda and I really wanted to highlight to sort of wrap up and bring us into questions. But, you know, I think we talked a little bit, we were able to touch on some of the unique concerns for adolescents of color, adolescents in urban environments, adolescents with medical illness. All of this really points to the idea that the notion of adolescence as this time for exploration and adventure is sort of mythical, and it really doesn't hold true for all emerging adults, and probably not for most of those that folks here today serve. That mental or medical illness presents some pretty unique challenges to meeting the developmental milestones of emerging adulthood, and that's a bidirectional relationship as well, because the challenges of emerging adulthood can make managing a mental or medical illness more difficult. And that there's a really critical lack of an underutilization of services in this really vulnerable period of development that requires us to kind of think outside the box. Are there other ways that we can meet the needs of emerging adults with new models that are effective and financially sustainable, and that really do consider contextual and individual factors? This idea of scaffolding is critical in this age group, and that it can be really helpful to also consider community partnerships to help us to fill in those gaps and to meet the broader needs of the patients and families that we serve. And I think that's it.
Well done. Thank you both so much. You guys are like the trifecta. You can tell that you're incredibly skilled clinicians because you're doing outstanding clinical work. And then also doing the research to support it and clearly excellent educators, because you did that in just the right amount of time and covered everything I think you wanted to cover in a very nice way. So kudos to you both. There are a couple comments in the chat. I'll just, I'll highlight maybe one, because I think this might have to, this sort of might highlight challenges across the board that some clinicians may be having, which is, I have a patient who's 15 years old, having a difficult time complying with medications, tracking glucose levels, etc. Mom is frustrated and angry. What do you do? I am curious from both or either of you to kind of tackle this in general, like what are some ways you may suggest? It's a big question, but any thoughts you have?
It is a big question, but I think that, and there are multiple possible answers and approaches, but I think especially in the context of what we've been talking about today, what's most important, effective, helpful tends to be identifying ways in which better managing one's diabetes in this example, but it could be whatever you want to say, better managing whatever one is dealing with, whatever the emerging adult is dealing with, will help them to meet their own goals. So are there ways in which not taking medication or not checking blood sugar levels is interfering in something that is important to them at this stage in their life, and that something about their lives would improve if they were doing that more consistently. So kind of classic example I use a lot is that you're not going to get an adolescent boy to check his blood sugar and take his insulin because he's worried about losing his eyesight down the line. That's not going to be the typical motivator. But if he can see that by checking his blood sugar before a sports practice and taking insulin, that his blood sugar is staying within the range that the research tells us is associated with peak athletic performance, and that then he's able to play more, spend more minutes in the game and fewer on the bench because he's not having to treat a low or a high blood sugar, then that's going to be motivating for him. Mm-hmm. So it's sort of tying it into what are the goals and tasks of emerging adulthood, and how can we sort of not have whatever a patient is struggling with at odds with that, but instead kind of working in sync with it.
I might just add, if it's okay, I agree with all of that. And the other side of it, I think, is helping mom, right? Like helping mom to maybe understand what's going on with her adolescent. Is he feeling, different from other kids? Is he anxious? Is he frustrated that he has to do all these things that other kids don't have to do? So helping her explore her own feelings, and maybe helping her to have a little bit more empathy for her teen's experience, which might pull down some of that irritation and allow her to communicate with him in a more effective way. Is one other piece I might consider.
It's a really good point. And I think the other thing is just showing empathy for parents. A lot of times I will just sort of use and put out there the example that I get it, that this isn't the same as sort of saying to a young adult, oh, sure, don't brush your teeth. See, you'll end up with a cavity. Or, okay, fine, spend all your money on that one thing that you want, and then you'll find you can't do this other thing. It's so much harder when we're talking about something, whether it's medical or mental illness, where for parents, it can really feel so high stakes and literally at times like it's a life or death consequence. And so just sort of acknowledging for parents that that level of anxiety is real and understandable, and it will make them more controlling and more anxious and high emotion. But unfortunately, that's not helpful in engaging emerging adults in self-care.
So well said by both of you. As a parent, I'm going to take that with me from this talk as words of advice in general. And again, we are out of time, but I think both of you had your contact info in there. You can obviously reach out to the Center for Faculty Development as well if you want to talk to them and get their contact info. But thank you again, Ellen and Amanda, for being here today. Outstanding presentation. Thanks so much.
Thank you so much for having us. Thanks, everyone.
Take care.
Bye.